Hello everyone, I'm Dr. Monica. Today we'll be discussing a very important topic that is gingivitis or gingival inflammation. So let's begin. So what is gingival inflammation? According to Jenko in 1990, gingivitis is the inflammation of the gingiva in which the junctional epithelium remains attached to the tooth at its original level, meaning that there is no attachment loss. Coming to the etiology, the most common cause of gingivitis is the presence of dental plaque. Gingivitis, it can also be altered by various factors like local factors which include presence of dental calculus, malocclusion, faulty dental restorations, and tooth anatomic factors. Some systemic factors which can alter gingivitis include hormonal changes associated with puberty, menstrual cycle, pregnancy, and disease like diabetes. Few medications such as cyclosporine, amlodipine, calcium channel blocker, and phenytoin also can alter the course of gingivitis. The latest classification of the dental biofilm-induced gingivitis is given by Murakami et al. In 2018. It is classified under three categories, that is, associated with bacterial dental biofilm only, potential modifying factors of the plaque-induced gingivitis, which is affected by systemic conditions, and oral factors which enhance the plaque accumulation. Third category is the drug-influenced gingival enlargements. The main characteristics of plaque-induced gingivitis include the disease begins at the gingival margin with the presence of dental plaque. There will be change in the gingival color and contour with change in gingival circular temperature. There will be presence of increased gingival exudate and bleeding upon provocation. In histologic section, there will be presence of an inflammatory lesion, and this gingivitis is reversible after plaque removal, and there is absence of attachment loss and absence of bone loss. Coming to course and duration, it is of three types, that is acute, chronic, and recurrent. Acute gingivitis, it is of shorter duration with a sudden onset, and the symptoms are usually painful. In chronic gingivitis, the duration is longer with slow onset. It is a fluctuating disease with painless symptoms unless it is complicated by acute or subacute exacerbations. Recurrent gingivitis, it is a type of gingivitis which reappears after having been eliminated by treatment or disappeared spontaneously. According to distribution, gingivitis can be categorized into five types. That is localized gingivitis, which is confined to the gingiva of a single tooth or a group of teeth. Generalized gingivitis, in this the entire mouth is involved. Marginal gingivitis, this involves the gingival margin along with portion of a contiguous attached gingiva. Papillary gingivitis, it involves the interdental papilla which can extend to the portion of gingival margin. Diffuse gingivitis, it affects gingival margin, attached gingiva, and interdental papilla. Talking about the stages in the pathogenesis of gingivitis, in 1976, Page and Schroeder divided the progressing lesion in the gingival tissue into four different stages, that is, initial, early, established, and advanced lesion. Initial and early lesion, they represent the clinically healthy gingiva histopathologically, and clinically the early stages of gingivitis. The established lesion, it represents the chronic gingivitis clinically. The advanced lesion, it is a phase when gingivitis progresses to periodontitis and there is consistently attachment and bone loss. Talking about the first stage gingivitis, that is the initial lesion. It is also known as subclinical gingivitis since at microscopic level there is presence of inflammation, but clinically the symptoms or the initial response of the gingiva to the bacterial plaque, it is not apparent. The first manifestation seen in the initial lesion is vascular changes, which consist of dilation of the capillaries and there is increased blood flow. In this diagram, we can see that the lymphocytes, they are going to be retained in the connective tissue when they come in contact with the antigen, cytokines, and adhesion molecules. While the neutrophils or the PMNs, they are going to migrate into the crevice area into the oral cavity, crossing the junctional epithelium. The fate of the initial lesion, whether it resolves rapidly or it evolves into a chronic inflammatory lesion, depends on the character and the intensity of the host response. If it does not resolve and evolve into this inflammatory lesion, then there's presence of macrophage and lymphoid cells after a few days. Talking about the second stage gingivitis, that is the early lesion. Early lesion evolves within 1 week after beginning of plaque accumulation. Clinically, it appears as early gingivitis and it overlaps with the initial lesion. There is no clear-cut dividing line between the two lesions. With time, there is sign of erythema and we can see proliferation of capillaries, increased formation of capillary loops between reti pegs. In the diagram, we can see dilated vessels and vascular proliferation, increased collagen loss. The main sign which differentiates it from the initial lesion is the presence of bleeding on probing. The vessels remain dilated and there will be increase in its number, due to which there will be increased redness of the marginal gingiva. This is the characteristic clinical symptom during this phase. Microscopic examination reveals that there will be leukocyte infiltration in the connective tissue beneath the junctional epithelium, mainly of T lymphocytes. Also, they will be migrating neutrophils as well as macrophages, plasma cells, and mast cells. When exposed to the chemotactic stimuli from plaque components, PMNs, they are going to initiate a series of coordinated actions in response to the infection. First, they will leave the blood vessels, then they travel to the epithelium, cross the basement lamina, and emerge into the pocket area. Then PMNs are going to attract the bacteria and engulf them in the process of phagocytosis. After this, they release the lysozymes which contain enzymes to break down the fibroblast. The fibroblasts they show cytotoxic stress with decreased capacity for collagen production. Now since there is more collagen destruction, it permits more leukocyte infiltration. Gingival fluid flow and the number of transmigrating leukocytes they reach their maximum between 6 and 12 days after onset of clinical gingivitis. Amount of collagen destruction also increases, and about 70% of the collagen it is destroyed around the cellular infiltrate. Circular and the dentogingival fiber assemblies are the most affected fiber groups. We can also see alteration in the blood vessel morphologic features and vascular bed patterns. So once the junction epithelium and the gingival sulcus they are densely infiltrated with neutrophils or PMNs, we can see retipex formation which invades the coronal portion of the lesion in the connective tissue. This represents an attempt by the body to enhance the mechanical barrier to the plaque bacteria and their products. We can see a niche between the epithelium, enamel surface and subgingival biofilm. Now the early lesion may persist for a longer period or they can develop into an established lesion depending on the susceptibility of the subject. Talking about the stage 3 gingivitis, that is the established lesion. It is characterized by predominance of plasma cells, that is B lymphocytes. We can see presence of small gingival pocket lined with pocket epithelium, and there is predominant of immunoglobulin G1 and G3 subclasses of B cells. In chronic gingivitis, which occurs 2 to 3 weeks after beginning of plaque accumulation, we can see blood vessels are engorged and congested, venous return is impaired, and there is sluggish blood flow. Localized gingival anoxemia, which superimposes a bluish hue on the reddened gingiva, is seen. Erythrocytes are extravasated into the connective tissue. There is breakdown of hemoglobin and its component pigments deepen the color of the chronically inflamed gingiva. The time for the development of the classic established lesion may exceed 6 months. Collagenase, which is responsible for the breakdown of collagen, it is normally present in the gingival tissue and some of it is produced by oral bacteria and by PMNs. In the inflamed gingival tissue, there is increased collagenolithic activity. We can see a inverse relationship between the number of intact collagen bundle and the number of inflammatory cells. The collagen loss it continues as the inflammatory cell infiltrate expands, which results in collagen depleted spaces extending deeper into the tissues, which then become available for infiltration and accumulation of leukocytes. Talking about the histologic sections, this shows intense chronic inflammatory reaction. A key feature that differentiates the established lesion is the increased number of plasma cells, which is the preponderant inflammatory cell type. Plasma cells it invades the connective tissue not only immediately below the junctional epithelium but also deep into the connective tissue around blood vessels and between the bundles of collagen fibers. The junctional epithelium reveals widened intercellular spaces filled with granular cellular debris, including lysosomes. These lysosomes they contain acid hydrolases, which destroy the tissue components. Now, the junctional epithelium they develop retipex that are going to protrude into the connective tissue, and the basal lamina is destroyed in some areas. In the connective tissue, the collagen fibers they are destroyed around the infiltrate of intact and disrupted plasma cells, neutrophils, lymphocytes, monocytes, and mast cells. Now the junctional epithelium is substituted by a pocket epithelium which is not attached to the tooth surface. This allows the further apical migration of the biofilm. Now the pocket epithelium it harbors large number of leukocytes, mainly PMNs. The pocket epithelium it is going to be more permeable compared to the junctional epithelium to the passage of substances into and out of the underlying connective tissue. Now this pocket epithelium may be ulcerated in places. The main features of the established lesion are this persistence of acute inflammation, predominance of plasma cells with no evidence of bone loss, there's persistence of immunoglobulins extravascularly in the connective tissues and junctional epithelium, there is continued loss of connective tissue substance, there is proliferation, apical migration, and lateral extension of the junctional epithelium. Early pocket formation may or may not take place. Talking about the stage for gingivitis, that is the advanced lesion, which is characterized by extension of the lesion into the alveolar bone. Gingivitis is developed into periodontitis in individuals who are susceptible. Microscopically, as the inflammation persists, we can see fibrosis of the gingiva. There is widespread manifestation of inflammatory and immunopathologic tissue damage. There is predominance of plasma cells in the connective tissue, and in the junctional epithelium and gingival crevice, neutrophils dominate. And as the pocket deepens, the gingival tissues they offer reduced resistance to the periodontal probing. The main characteristic of this lesion, that is advanced lesion, is the loss of connective tissue attachment and alveolar bone. Talking about the features of advanced lesion, there is persistence of features described for established lesion. There is extension of lesion into the alveolar bone, periodontal ligament with significant bone loss. We can see continued loss of collagen subjacent to the pocket epithelium with fibrosis at more distant sites. There is presence of cytopathically altered plasma cells and formation of periodontal pockets. We can also see widespread manifestation of inflammatory and immunopathologic tissue reactions. Coming to the clinical features of gingivitis, the clinical signs include redness and sponginess of the gingival tissue, changes in contour, consistency, position, presence of calculus or plaque with no radiographic evidence of crestal bone loss, bleeding on provocation. The two earliest signs of gingival inflammation preceding established gingivitis are increased gingival crevicular fluid production rate and bleeding from gingival sulcus on gentle probing. The color changes in acute gingivitis. The color changes may be marginal, diffuse, or patch-like depending on the underlying acute condition. As we can see in ANAC, the involvement is marginal. In herpetic gingivostomatitis, it is diffuse. and in acute reactions to chemical irritation, it is more like a patch or diffuse. Color changes it vary with the intensity of inflammation. Initially, they can be increased in erythema. If the condition does not worsen, this is the only color change until gingiva reverts to normal. In severe acute inflammation, red color gradually becomes a dull whitish gray. The gray discoloration produced by tissue necrosis, it is demarcated from adjacent gingiva by thin, sharply defined erythematous zone. The color changes in chronic gingivitis. Chronic inflammation intensifies the red or bluish red color because of vascular proliferation and reduction of keratinization due to epithelial compression of the inflamed tissue. Venous stasis, it is going to contribute to a bluish hue. The changes start in the interdental papilla and marginal gingiva, which spread to the attached gingiva. Proper diagnosis and treatment require understanding of the tissue changes that can alter the color of the gingiva at the clinical level. Please like and subscribe this channel.